All right. Hope everyone can hear me and see my slides. So wanted to acknowledge Ball and Alex for two great talks. Thanks so much. And I'm going to shift gears here a little bit and talk about a vulnerable population that I think some of us have probably had interactions with. Certainly, the care of inmates with kidney diseases is part of our practice at Harborview. And it was part of my practice when I was down at San Francisco General Hospital, but actually until recently, I knew extraordinarily little about their healthcare structure. And so I'm going to talk a little bit about the structure, some of the processes and outcomes of care of inmates with chronic and end-stage kidney diseases. Sorry, I'm frozen up here. All right, so in terms of kind of the inspiration or the rationale behind this talk, I had the great fortune to meet a man last year who told me this extraordinary story of his experiences and travels through the U.S. correction system as someone with first chronic and then end-stage kidney disease. And so, and I think this is a remarkable story that illustrates some of the vulnerability of these individuals. And so last year, Ben and I were on call together, and we got called down to the medical ICU to assess an inmate who had come in from one of the correctional facilities in Washington State. And we had absolutely no information other than the guard told us that he had refused to dialyze. And when we got there, we found this man who was completely altered. He was twitching. He had some of the most severe electrolyte and acid-base abnormalities that we see at Harborview, and we do occasionally see some severe ones. And he was shackled to the bed. And so after kind of providing emergent dialysis and then urgent and then daily dialysis for a few days, he woke up, and when I asked him sort of why he had refused to dialyze, he told me this extraordinary story, and I'm going to relate it a little bit to you right now. So his story actually starts out in Walla Walla, Washington, where I think many of you know the Washington State Penitentiary is located. It's the maximum security prison of Washington State, where capital punishment was formally carried out until I think 2018, when it was ruled unconstitutional. And it's also known as Concrete Mama after this book by Ethan Hoffman and John McCoy, published in UW Press. But it was there he was told that his kidneys were failing and that he had severe hypertension. He saw a local nephrologist who came into the facility once and provided him with some antihypertensive medications. And that was really the extent of his interaction with the nephrology community. At some point, he was transferred to the federal system. And, as an aside, inmates will generally transfer for three reasons. One, for their safety. Two, for facilities or services that are better suited to their current needs. And then three, to be closer to friends and family as they get closer to reentry. And so it sounds like he was transferred more for the first reason. He had run afoul of one of the affinity groups at Walla Walla and was transferred for his safety to the federal system. But ironically, he became progressively ill and uremic and had to start dialysis emergently through a catheter at the University of Arizona. And because the USP Tucson has no capability to support the dialysis needs of an inmate, he was transferred very quickly to the U.S. Medical Center for Federal Prisoners, which is in Springfield, Missouri. And I learned it's a maximum security prison. And he described essentially this warehouse, a cinder block warehouse of numerous dialysis stations where mostly African-American men like himself were dialyzing under high security conditions. And he dialyzed there for roughly about 2 years until he got into an altercation with one of the techs who reportedly threatened to kill him by infusing something into his bloodlines. And so he was again transferred for his safety to another prison in Devens, Massachusetts, a medium security prison with on-site dialysis, where he actually learned about a program that the Bureau of Prisons had that sponsored transplants, kidney transplants in like highly selected inmates. And he began clamoring for a kidney transplant. And he attributes this to him being blackballed or blacklisted, and then transferred out of that prison to another medium security prison in Butner, North Carolina, where he claims to have dialyzed next to what he called the world's greatest criminal, who was Bernie Madoff. Some of you have heard he has had to initiate dialysis in prison from the Ponzi scheme of about a decade ago. And then finally, he put in a request to come back to the state of Washington to be closer to friends and family. And that request was granted in 2019. And so he was transferred back to the state system, to the Monroe Correctional Complex. And 5 years after initiating dialysis, he had a left brachiocephalic fistula placed at Evergreen Hospital. But it was also at Monroe where he became increasingly concerned about the quality of care that was being delivered there. And he cited a number of different things related to dialysis, but he was concerned about the lack of hand hygiene protocol in the dialysis unit. He said that there was a lot of medical waste that seemed to be kind of overflowing from bins and then also strewn on the floor. He said that, compared to the federal system, the cleanliness of the facilities was very, very poor. And he began bringing up a lot of these issues to the leadership there and to the medical director. And it apparently fell on deaf ears. And so he finally, in protest, decided not to dialyze anymore. And that's how he came to Harborview. And so after a few days of dialysis, he was kind of whisked away back to Monroe, unfortunately, only to present like 8 or 9 days later with the exact same presentation, only he didn't survive that second admission. So what I'd like to do is kind of put a little context to his presentation, talk about mass incarceration in the United States, and kind of bring this closer to nephrology, talk a bit about the rising prevalence of risk factors for chronic and end-stage kidney disease in the incarcerated population of the U.S. Talk about what little we know about care access and the cost of this care, as well as some interventions that are more specific to the delivery of kidney-related care, which I think holds some promise for reforming this. All right, so the United States, just like COVID-19, we are like the world leader in mass incarceration. We incarcerate more people per capita than any other country in the world, including El Salvador, Rwanda, Russia, China, Brazil. Some of these countries not necessarily known for their sterling record on human rights. And in fact, if we gathered everybody at any given cross-section in time who's incarcerated in US jails and prisons, we would actually be able to form like the 4th or 5th largest city in the United States, behind just New York, LA, Chicago, and right around the size of Houston. And this kind of Gotham City, if you will, would have roughly about 1.3 million people coming in from state prisons, another 250,000 from federal prisons, and then the remainder, 600,000 or 700,000, kind of churning through local jails. So it wasn't always this way. You can see these are the number of individuals who were incarcerated in state and federal prisons over the course of the last century. And back in the 1960s and early 70s, actually, roughly, we had about 200,000 people in prison. But there are a number of federal policies which have kind of changed this dynamic and led to this rise in mass incarceration. And you can see I've highlighted 2 of them because they kind of comprise this war on drugs. And so the first was passed during the Nixon administration. And I think we're all familiar with this because this is the basis of our controlled substances. But it was really the second, the Anti-Drug Abuse Act of 1986, passed during the Reagan administration, that effectively shifted federal policy from one of rehabilitation to one of penalization or penalization. And it introduced a number of measures, including minimum mandatory sentences for drug-related offenses, even drug-related offenses related to possession or distribution of marijuana. And as such, the prison population has grown 700% in the interim 3 or 4 decades. And ironically, this growth, this rapid growth in mass incarceration continued almost unabated, even in the setting of declining rates of property and violent crime that we observed in the late 80s and early 90s. And this has come at considerable cost to society. So for example, in the 1980s, states were spending roughly about 6 to 7 billion on corrections. And this has gone up and up and up and up. And now we're spending roughly between 60 to 70 billion dollars on corrections. And in the federal system, it costs roughly about $105 a day now to incarcerate an individual. And that equates to roughly about $37,000, $38,000 a year per inmate per year. All right, so the corrections process occurs in 4 distinct phases, going from arrest to sentencing to incarceration and then to re-entry. The first 2 typically occur in jail, and then the second 2 typically occur in prison. And I just want to, I'm not going to spend a whole lot of time on this, but I just want to highlight the difference between jail and prison. I know many of you know this, but we tend to use the terms kind of synonymously or homogeneously, but they're very different experiences. And so jail is really a short-term confinement facility. It's for people who are awaiting trial. It's under the jurisdiction of the local law enforcement, and it has a single level of security. And confinement, as well as access to care, healthcare, is highly varied. Prison, on the other hand, is a long-term confinement facility. It's for people who are post-adjudication. It is under the jurisdiction of either the state or the federal government. It has multiple levels of security, and conditions are much more consistent, particularly in the federal system. And this is particularly related to access to healthcare. And so 2 other terms that you'll find: probation and parole. Probation actually is often part of the sentences, kind of served in lieu of prison time, while parole is what we would consider early conditional release, and so medical parole, for example. All right, and so why is this relevant to us in nephrology? Well, you'll find actually that inmates or people who are at risk for incarceration also actually share a number of risk factors for chronic and end-stage kidney disease. I think it's no mystery that people of color are incarcerated, at least in the United States, at far higher rates than non-Hispanic white Americans, in particular Black Americans, and in particular Black men. I think the lifetime risk of incarceration as a Black man is something astronomical, like 1 in 3. Recall, I think Bessie showed us this figure. I've showed you this figure many times, that I think we all know that rates of end-stage kidney disease, so incidence rates of end-stage kidney disease, are also higher among people of color, and in particular Black Americans. The prison population also, like 80% of prisoners, live below the federal poverty line and have very limited access to medical care leading up to incarceration. And we and other people have shown numerous studies describing a very strong association between the level of neighborhood poverty and incidence of end-stage kidney disease. This is data from Natalie Volkova and Bill McClellan's group, which I've shown you before, down in the southeastern United States, showing you a marked and graded increase in the rates of end-stage kidney disease according to the degree of census tract poverty, where those individuals living in very high areas of poverty have roughly 3 to 4 times higher rates of end-stage kidney disease than those in the more affluent areas. Another factor is that the demographics of the inmate population are actually changing quite dramatically. And so, for example, in the mid-'80s, in other words, we are doling out longer sentences and then more life sentences. So in the mid-'80s, you can see that there are roughly about 34,000 people serving life sentences in the United States, and that has grown and grown and grown. And now there are roughly about almost 250,000 people serving life sentences. And in addition to the life sentences and the longer sentences, this has largely driven a change in the demographic population of inmates. And so while in the 1980s, inmates were largely young men or younger men, that demographic has changed, and now like 1 in 5 inmates is at or above the age of 50. And that has changed 5-fold over the course of the last 2 or 3 decades. And with this has come a change in the chronic conditions that we're observing in inmates. And so this was the last survey of inmates. It's kind of like, I would consider it like the NHANES of inmates in state, federal prisons and jails. And that was conducted almost a decade ago. And I can guarantee you the prevalence of these conditions have only been going up since then. But even then, you can see that the prevalence of certain conditions that are considered, sort of major risk factors for chronic and end-stage kidney disease, like hypertension, like diabetes, certainly heart disease, are much higher in prevalence in the inmate population than in the general population. You can see like 1 in 3 inmates actually had hypertension at the time of the survey, 1 in 10 with diabetes, around the same number with heart disease, and already about 6% of the inmate population then had some kind of recognized kidney, quote, problem. And this is in addition to sort of the infectious diseases that we see, the chronic viral diseases, which in themselves carry some risk for chronic kidney disease. Also at the time of this particular survey, and this is data from Emily Wang that was published in JACC a few years ago, nearly 3/4 of all inmates who were surveyed were either overweight, obese, or morbidly obese. I've also highlighted some of the federal policies that have led to a rise in incarceration for drug-related offenses, and these are just pure drug-related offenses, typically either possession or distribution, not related to violent or property crime, related to drugs. But in every sector, so the federal, the state, as well as the county jails, the number of people serving drug-related offenses has increased like 10-fold to 20-fold over the course of the last 20 years. And we know, based on our own local data from Brian Kestenbaum, as well as data from Jason Bundy and the CRIC group, that use of hard illicit substances such as cocaine, such as methamphetamines, and in particular heroin, and in particular black tar heroin, are associated with much higher risk of progression of chronic kidney disease, and certainly in Brian's study, and what we observe almost on a daily basis here at Harborview, the extraordinary risk of end-stage kidney disease associated with black tar heroin. All right, so what do we know about healthcare access and the quality of this care to inmates? And so I learned that constitutional law actually protects the right of inmates' access to care. And this is based on a decision from the Supreme Court that was dealt in 1976 when J.W. Gamble, who was a black man in the Texas prison system, actually sued the warden who forced him to actually bail cotton multiple times, despite the fact that he kept collapsing. And one day he was actually taken to a local hospital, and it was found that he had an arrhythmia. I think it was AFib with rapid ventricular response. And he actually sued the warden by writing his complaint down on a napkin. And the Supreme Court ruled that actually denying inmates access to care constituted cruel and unusual punishment and actually violated the Eighth Amendment. But what is actually in law or constitutional law and what is practiced are two very different things. And so this was actually, like the absolute last study or survey performed by the CDC regarding access to care for inmates in U.S. jails and federal prison. And this is data from Andrew Wilper, published over a decade ago when he was, I think, an HSR&D fellow here at the university. He's now the associate program director, I think, for medicine in Boise. And what you can see is that he examined several measures of care access, including like, did people have a documented exam for a medical problem? Did they have a medication prescription for an active medical problem? Or did they have a blood test for a medical problem requiring routine blood tests? And what you can see is there's a high degree of variability, but the county jails or the local jails have the absolute worst access to healthcare, which is far worse or far lower than at the state level. And it seems like the federal system probably has the most consistent sort of medical care access. And I actually remember one of my patients now that he was receiving maintenance dialysis down at one of our units in the South End. And one day he kind of disappeared, and we were calling around after he missed 2 treatments, and his family said that he was actually incarcerated in one of the county jails. And so we were calling around to all these county jails in Washington State, and we couldn't find him. And it ended up he was actually incarcerated down in Southern Oregon, where he'd gone, and he describes it, to extricate his daughter from a difficult situation. And he ended up in county jail down in Southern Oregon. And my suspicion is because he's a very muscular Black man with a sort of an inconspicuous fistula, they didn't believe him when he said that he required maintenance dialysis until he actually started vomiting all over the place and had to be treated emergently like 8 or 9 days after he had been incarcerated at the local hospital down there. So prison healthcare is organized according to 4 levels. Individuals who require maintenance dialysis are categorized in level 4, which is considered severely impaired. And these are people who may require daily nursing care, includes individuals who are post-op or those receiving active chemotherapy, having an active or acute psychiatric condition, or some of the women with high-risk pregnancies. And so the care, the dialysis care is actually highly concentrated in relatively few facilities, and this is both at the state level and at the federal level. And so at the federal level, there are actually only 4 dialysis units providing the vast majority of dialysis care, and they are divided up based on the security level of the prison. And so, for example, the Federal Medical Center in Lexington is a low security prison where actually dialysis inmates who require dialysis actually get on a bus, and they actually bus out to a community provider. And so it's contracted out to the community provider, receive their dialysis, and actually bus back. In medium and high security prisons such as Devens, Butner, and certainly the U.S. Medical Center for Federal Prisoners, which was actually formerly known as the U.S. Hospital for Defective Delinquents, apparently. But those prisons actually have on-site dialysis, which is typically delivered in relatively high security conditions. But I could not find anything, either published or reports, even in the government websites, on the number of patients who are actually receiving dialysis behind bars. So here in Washington State, all of the dialysis care actually is concentrated at the Monroe Correction Center, which you can see, you can see the high guard towers and the walls and the perimeter fencing is a multi-security prison located up in Snohomish County, just I think east of Everett. And so in Washington State, we have, I think, 12 prisons that form the Department of Corrections. And according to my patient, Monroe has roughly about 10 dialysis chairs. It's under the care of Seth Thaler, who's actually a private nephrologist and is part of the Olympic group down in Olympia. And this sort of structure of on-site dialysis actually is quite common within the State Department of Corrections. And you can see to the right here, this is a CDC study showing you that about half of the State Department of Corrections have on-site dialysis, and then Texas and California seem to have the largest populations of inmates requiring maintenance dialysis. And then about 10 states have contracted this out off-site, while another 10 states have sort of a hybrid between both on-site and off-site dialysis. And it's likely based on the security needs of the inmates. The other one thing, though, is that I couldn't find any sort of quality metrics related to the provision of this care. I know, at least based on the lay press, this was from the Herald Everett from a couple years ago. Certainly the quality of medical care at Monroe has come under great scrutiny. The medical director there was actually placed on leave and then fired, and is still under investigation for the unusual deaths of 7 inmates. And so some of the complaints that Mr. W., my patient, was mentioning probably were, it sounded like were very true. There are no uniform quality of care standards for corrections system, nor really a mechanism for reporting kind of performance data or any ability to compare performance data. And so while I told you that the vast majority of State Department of Corrections provide either on-site or off-site dialysis, there are only 19 states that follow any kind of metrics around the provision of care for patients with end-stage kidney disease. And this is from the Pew Charitable Trust. Washington State actually is not one of them. And so that's why I wasn't able to find any care metrics. This is Jeffrey Beard to the right here. He's standing, you can see he's staring at dialysis station number 29. He is the secretary of the California Department of Corrections, and they have built a flagship kind of medical facility at their Stockton prison, and have brought all of their patients, it sounds like, at least in Northern California, to that prison for at least the inmates who required maintenance dialysis. And part of this is because of numerous lawsuits that have occurred in the early 2000s, so much that actually the Department of Corrections, the healthcare there, has been placed under receivership because of perceived inadequate or poor quality of care provided. All right, and so in this last couple minutes, I'm going to just highlight a couple things interventions that relate to the provision of kidney-related care that have promise for potentially reforming this care. And so, you know, I didn't know this, and probably our VA colleagues do, that telemedicine actually is the dominant care model for many specialists in the prison system. And so this was based on a CDC study where a couple years ago, where it looked like about 30 Department of Corrections at the state level where it had an active telemedicine program. And you could see most of them reporting substantial benefits with the use of telemedicine. And it's a huge cost savings because it costs a lot of money to transport an inmate, often from a rural facility to an urban medical center. And that's not including the personnel costs. Typically, they have to be accompanied by at least 2 guards. But what I also learned is that very few states, actually only one, Delaware, actually have a telenephrology program. And I think, you know, the VA colleagues have known this for a while, but I think we've all recognized that telenephrology has potential application for, you know, particularly for individuals who are isolated. And I think it's particularly useful modality, or potentially useful modality, for providing sort of timely specialist care to inmates with chronic and end-stage kidney diseases. And, you know, like in many things, we kind of lag behind some of the other subspecialties. Certainly cardiology and oncology have active telemedicine programs in 12 and 7 states respectively, with the dominant modality being for psychiatric care. I also learned that in 2001, the Federal Bureau of Prisons actually reversed a longstanding policy and decided to pay for organ transplants in select inmates. And my patient was actually quoted here in the Washington Post when he was an inmate at Devon's, saying that the staff there were actually trying to discourage patients from pursuing kidney transplants. And you can see OPTN and UNOS actually take kind of a middle ground on this and say, you know, the status of a prisoner really doesn't guarantee but doesn't also preclude one from receiving a kidney transplant. And there is only, I think, 2 studies in the medical literature, and this was a pretty recent one that was published in Transplant on the Erie experience. And so they've had actually a kidney transplant program for inmates since 2003. And, you know, over the course of the last 15 years, 27 have been listed and 20 have received, it sounded like mostly deceased donor kidney transplants. And you can see the 1- and 3-year allograft survival rates there. Many of them have been released or re-entered society, and they have long-term follow-up on 9 of 20 of them. But their kind of crude cost models show a substantial reduction in cost at 3 years, and certainly thereafter, you know, particularly when compared with the cost of providing maintenance dialysis. And then this is my last slide, but this is a famous publication by Ingrid Binswanger, who is a HSR&D fellow here at the time that she published this in the New England Journal of Medicine, showing you this very high vulnerability of Washington state inmates as they re-enter society, this spike in deaths in the first 2 weeks. And while a large fraction of these deaths were due to opiate overdoses, a sizable fraction of these deaths were due to medical conditions such as heart failure and end-stage kidney disease. And it's interesting because this reentry to society is something that we actually observe at Harborview when inmates are getting ready to be released. There's a clear lack of care coordination, and I learned that only 27 states actually have targeted continuity care services for patients with end-stage kidney disease, which typically entail helping them apply for insurance and then coordinating referrals to community-based providers. All right, so I'm going to go ahead and wrap up here. Just in summary, the U.S. is the #1 mass incarcerator in the world. That we have, in terms of the relevance to the nephrology community, I think we should be concerned because there are a number of risk factors that are present in the inmate population that pose substantial risk of both progressive chronic and then certainly end-stage kidney disease. There are huge knowledge gaps in the provision of this care, as well as even just the number of people receiving care for end-stage kidney disease behind bars. There's virtually nothing on the quality of care, and this is, I think, a huge barrier to this. There are a number of interventions that I think hold promise for potentially reforming this care, both in terms of improving the quality and reducing costs. And I want to give a shout out to Amol and Leah, who I think performed the very first telenephrology visit for an inmate in the state system, I think last week or a week or two ago. We originally saw him in person, and he was getting ready to transition to being released. And I think Amol and Leah followed him up with, I think, the very first telenephrology visit for a state inmate. So, all right, so I'm going to go ahead and wrap up here. Sorry, I've gone over a little bit, but I'll take any questions that you might have.
I think we have time for 1 or 2 questions for Dr. Hall. People can raise their hands or type. I'll just read the one comment from Dr. Struthers. I did 2 telehealth clinics per month for inmates across Louisiana, 20-minute appointments for very sick patients, and all discontinued when the pandemic started. I worry what happened to these folks. Any other comments, questions? Yoshio, do you know why telemedicine has not had greater uptake here in Washington and within nephrology?
Yeah, I think some of it depends on the cost structure. Most in-prison care is not covered by Medicare or Medicaid, and so it's often negotiated, by the prison, typically at Medicaid rates. But in the CDC study, 3 most common barriers, I guess, to telemedicine as a whole were one, just the cost of the equipment. 2 was actually resistance from providers, and then 3, the hassle of kind of organizing or coordinating this across different sites.
Well, thank you so much, Dr. Hall. I'll turn things